For decades, cardiovascular risk assessment relied on basic factors like age, sex, and total cholesterol. Clinicians used the ACC-AHA pooled cohort equations to determine who should receive primary prevention therapies, such as statins or antihypertensive medications. While these models are effective for large-scale population statistics, they frequently fail at the individual level by overlooking residual risk factors. This creates a clinical blind spot. Patients who meet every standard guideline for lipid health but still experience acute coronary syndromes without warning. The rising global burden of cardiovascular disease indicates that relying on population-level statistical guessing is no longer sufficient for individual care. Precision cardiology addresses this by shifting toward granular, individual-specific measurements of a patient's biology and anatomy. The process begins with Layer 1, establishing a clinical baseline using the updated PREVENT equations, which incorporate kidney function and improve calibration across diverse populations. The model adds 3 subsequent layers, measuring specific genetic predispositions, markers of active biological inflammation, and direct anatomical visualization. Integrating these specific, highly detailed variables brings the advanced capabilities of modern cardiovascular research directly into routine clinical practice. Synthesizing these biological and anatomical signals into a single workflow allows a clinician to intercept the disease before it reaches a critical state. Layer 2 involves mapping genetic predisposition, specifically by measuring lipoprotein A. Lipoprotein A is an LDL-like particle with a unique protein tail, Apolipoprotein A, which makes it both highly atherogenic and prothrombotic. 20% of the global population harbors elevated levels of this particle, significantly increasing their risk for heart attack and stroke. Because levels are genetically determined and largely unaffected by diet or exercise, current guidelines recommend testing every adult at least once. Beyond genetics, we have to look at how we measure circulating lipids. Measuring cholesterol by weight is a biologically limited metric. Apolipoprotein B, or ApoB, provides a more accurate measurement by focusing on the total number of atherogenic particles in the blood. Every harmful lipoprotein particle carries exactly 1 molecule of ApoB on its surface, making an ApoB count a direct measurement of total particle traffic. Atherosclerosis is driven by the absolute concentration of particles invading the arterial wall, making ApoB a superior therapeutic target compared to standard LDL-C mass. This distinction is critical for patients with insulin resistance or type 2 diabetes, who often exhibit clinical discordance. As this chart shows, these patients can present with low cholesterol mass while simultaneously maintaining a dangerously high count of small, dense LDL particles. Because of their reduced diameter, these small, dense particles easily penetrate the endothelial barrier and bind to the arterial wall. These particles also have a reduced affinity for receptors that would normally clear them, meaning they circulate in the plasma for much longer. Treating these metabolic patients based on standard LDL-C targets alone leaves their true particle burden and their true risk unaddressed. Layer 3 assesses biological activity to determine if the atherosclerotic process is actively inflamed. High-sensitivity CRP is a well-established marker for measuring systemic inflammatory residual risk. However, we can now track localized vascular inflammation using an enzyme called LPPLA2. Produced by macrophages within the plaque itself, LPPLA2 breaks down oxidized phospholipids, releasing mediators that promote plaque instability. This process creates foam cells and degrades the plaque's fibrous cap, moving it closer to a rupture. Incorporating markers of cardiac stress, such as NT-proBNP and high-sensitivity troponin, further increases the accuracy of risk reclassification for asymptomatic patients. This Layer 3 data provides evidence of a plaque's current activity, identifying necrosis and active inflammation before it leads to rupture. Layer 4 moves into direct anatomical visualization, shifting the diagnostic focus to physical disease mapping. The Coronary Artery Calcium score currently serves as the gatekeeper for deciding who needs statin therapy in intermediate-risk cases. A CAC score of 0 provides high negative predictive value, which has historically been used to defer treatment. But CAC scans have a specific anatomical limitation. They only detect calcified, stable plaque. This is the zero calcium paradox. Relying solely on this score misses the non-calcified, soft plaques that are often the actual cause of heart attacks. To solve this dangerous paradox, clinicians now use AI-guided CT Coronary Angiography to directly identify the hidden soft plaques that traditional calcium scores completely miss. Platforms like AI-QCT automate the detection and quantification of this non-calcified plaque burden. These tools identify high-risk features, like low attenuation plaque, indicating a necrotic core. They also detect the napkin ring sign, a marker of thin cap fibroatheroma. Recent studies indicate that up to 20% of asymptomatic patients with a zero calcium score actually harbor clinically relevant non-calcified plaque. Integrating AI with imaging allows cardiologists to move past probability estimates and start quantifying a patient's exact physical vulnerability. The final workflow synthesizes prevent baselines, advanced biomarker testing, and AI-guided anatomical staging. Trials like Scott Hart have proven that using advanced imaging to reclassify patients leads to a direct reduction in myocardial infarctions. While implementation is currently slowed by insurance barriers and upfront costs, economic modeling supports the shift. As this model shows, the initial cost of advanced testing is offset by a significant long-term reduction in the costs of acute care and emergency interventions. Implementing precision cardiology reallocates capital from late-stage emergency interventions toward more effective early prevention. The long-standing reliance on population averages and singular LDL cholesterol targets is evolving. The data supports adopting a clinical approach focused on lower for longer and earlier data-driven intervention. By integrating biological signals with AI-driven imaging, clinicians can finally identify the right risk in the right patient at the right time.